I'd like to thank everybody for coming today to our inaugural colorectal circulating tumor DNA symposium. We've titled this symposium Intercepting Minimal Residual Disease Through Clinical Trials. And I think we have an exciting day lined up for you. I do realize it's Friday afternoon, so one of our key objectives will be to get everybody out on time. But we really want to just kind of focus in the next kind of 3.5 hours or 4.5 hours on a lot of the exciting work centering around circulating tumor DNA, specifically for colorectal cancer. And we believe that much of this can be applied towards management and oncology of other patients as well. So kind of with that said, we have a packed agenda for today. And I want to just start off. My name is Van Morris. I am an associate professor in the Department of Gastrointestinal Medical Oncology here at MD Anderson. I treat patients with colorectal cancer and anal cancer as well. I want to just kind of give a highlight of circulating tumor DNA. You'll be hearing a lot of these themes in greater detail with our speakers throughout the course of the day. But I really want to just kind of kick this off with why we think that this is important, and some of the just kind of high-level overview of how we're incorporating this into the management of patients with colorectal cancer. We hear about this, unfortunately, in the news too much these days, and I can venture to say that most people in this room have been in some way personally affected by a diagnosis of colorectal cancer, whether this is you yourself, a family member, or a friend. I think, unfortunately, we probably could also all name an instance or how this affects us personally. Colorectal cancer is the second leading cause of cancer-related death in the United States. And in very worrisome data that was published earlier this calendar year, we're starting to see that for both men and women alike, under the age of 50, you can see in the red arrows here that with colorectal cancer, early onset colorectal cancer, the rates of death for colorectal cancer are the ones that are rising. Across other disease types, the trends are all heading in the right direction, fewer related deaths, but very concerning that we're seeing worsening trends, especially in our patients under the age of 50 with colorectal cancer. We're here at MD Anderson and in the Texas Medical Center because our goal is to help patients with cancer. Our goal with our group is to cure more patients with cancer. We're very keen and intent on using this technology to identify patients who are at high risk of their cancer coming back with the goal for cure. So we're setting the bar high because our patients need it. And what you can see here in data that was we pulled from the SEER national database, you can still see that in the figures on the left here, the majority of patients still, when they're diagnosed with colorectal cancer, are being diagnosed with earlier stage localized disease. But when you look at where we are, you can see that whether it's localized disease, regional lymph node involved disease, or even distant metastatic disease, there's still significant room for improvement, still an opportunity to cure more patients with this disease. And again, our goal is to help do that, to utilize this technology to identify patients who need to clear this, who still have yet to clear this bar and are in need. We'll be talking about this more throughout the course of the day with how our group at MD Anderson and across the Texas Medical Center is really looking actively to do that. Circulating tumor DNA in general, we view as one part of and probably the most studied part of the liquid biopsy. The nice thing about circulating tumor DNA is that the results that you get out of this really inform on what's happening in real time with that patient. The half-life of circulating tumor DNA in a patient's bloodstream is in the order of hours. So you really are getting a real-time analysis of what's happening. We could certainly spend a week conference talking about the implications of the liquid biopsy in the management of patients with cancer. This is just a high-level overview and a really nice review that was published and led by Dr. Arvind Dasari in our group. You can refer to this review in Nature Reviews Oncology from 2020. But what you can see here is that there are, this technology of circulating tumor DNA can be applied across the clinical spectrum of patients with colorectal cancer. Certainly for patients with localized disease, as we'll be talking about later, monitoring and prognosticating for recurrence and looking for minimal residual disease. In patients with metastatic disease, we're using this to personalize treatments, understand resistance mechanisms, really to treat a patient as an individual and not as part of an entire population. A lot of the questions we get, and we're not going to get too much into the weeds of this today, are can I just use any assay for checking a patient for ctDNA? And I think it is important to understand that these assays are not all created one and the same. They're tissue-informed assays, which incorporate, an individualized test for that patient. Technologies which use whole exome sequencing, now whole genome sequencing of a patient's tumor to really provide us with highly sensitive, highly specific approaches towards informing on, a minimal residual status. There are also tissue agnostic assays as well. These come obviously not requiring tissue, a rapid turnaround time. We recently built an assay for HPV ctDNA where you don't need tissue, and we're using that to survey our patients with HPV-associated malignancies. So again, the context matters, but knowing a little bit about the specifics of the test you're ordering, I think is helpful to make sure you're answering the question best for your patients. For metastatic patients, and again, a little outside the scope of, I think, today's talk, but really can inform on the presence of actionable mutations. We will be using this for DYPD testing, given the new FDA guidelines in the months to come, and understanding drivers of acquired resistance to targeted therapies. And again, we're talking a lot about the liquid biopsy. We're talking a lot about circulating tumor DNA, but just keep in mind, there's a lot of work out there that goes beyond just the DNA and really getting at the biology of patients with colorectal cancer. So our goal, one of the questions we get a lot from an outside oncologist is, my patient has finished their treatment, they're on surveillance, they have a ctDNA positive result, and I don't know what to do with that. We've heard this from patients. I don't care what you give me, just give me something. I think that we're all kind of getting at the same point here. If a patient is ctDNA positive, as we'll talk about throughout the course of the day, we know that there's a high risk that this patient is likely to develop recurrent disease. And we need to think about escalating and introducing therapies that can hopefully, catch these patients quickly and convert these patients to a negative status. Whereas, maybe they're ctDNA after their surgery and they don't need all the therapy that you were otherwise planning to give. Can we de-escalate their therapy, get them still to the curative outcome, but in doing so, minimize the long-term toxicity that the patients are getting? So a lot of studies have looked at this. Briefly, Galaxy is, I think, one of the more cited ones in patients with colorectal cancer, but was a large observational study that used a tumor-informed ctDNA approach. And what they saw was that in patients who had no detectable circulating tumor DNA, in the figures, you can see at the top, the prognosis was much more favorable. These patients in the surveillance period were much less likely to have their cancer come back, whereas there is an inevitable recurrence if the patient is ctDNA positive, that their cancer, they still have some, albeit microscopic levels of disease, but their cancer is likely to come back. As these patients get chemotherapy, we saw out of Galaxy that patients who convert from a ctDNA positive to a ctDNA negative result in the blue here are likely to fare much better than those patients who don't clear at all or have some transient clearance where you see it for some finite amount of time become undetectable and then convert back to a positive status. So this was a large observational study, and we know that, in the surveillance period, if the ctDNA result does turn positive after they've completed their standard of care therapy, a high likelihood that that cancer is going to recur. And this has really been an interest for our group at MD Anderson. How can we go beyond the standard of care to bring new and biologically informed trials to our patients? So if a patient is CTA positive, do I need to throw the kitchen sink at them, the proverbial kitchen sink at them, I should say, and escalate, be as aggressive as possible because they're at high risk for recurrence? Multiple trials are starting to look at this in a randomized setting to provide the missing level 1 evidence we need from randomized trials. This was a trial that we led at MD Anderson across the United States and Canada, where we looked at patients with stage 2 low-risk disease. And we looked and we saw, if for patients who are ctDNA positive and get, recommended standard procedures, which would be active surveillance, how do they fare then if you give these patients chemotherapy for a ctDNA positive result? Our hypothesis was that we would see clearance of the ctDNA with FOLFOX chemotherapy in these otherwise low-risk stage 2A positive patients who had detectable circulating tumor DNA using a tumor uninformed ctDNA assay. We didn't see that with this study and with this assay. So a lot of work is kind of happening now to try to understand, why this was observed. But I wanted to kind of highlight, a second randomized study which reported out last year at ASCO. This was an Australian study, which this time used, as you can see in the green here, a tumor-informed approach, and looked at patients who with stage 3 colon cancer who were ctDNA positive, and if they were either randomized to standard management or a ctDNA-informed approach. And if they were ctDNA positive, as you can see in the pink here, that provider then was informed to escalate the chemotherapy according to the schedule you can see here. It's important to note with this study that there were multiple treatments a patient could get according to how the oncologist had planned chemotherapy going in. But very interestingly, with this escalation approach and a second randomized study, now using a tumor-informed approach, you did not see improvement of outcomes with chemotherapy. So again, I think there's a lot of caveats, about this study, but I think the results, to me, I would say were surprising. We didn't see any improvement with treatment escalation in this high-risk stage 3 population. I want to highlight, a study being led by Dr. Arvind Desari in our group and our friend Dr. Chris Liu at the University of Colorado across the United States and Canada as well. This is a Circulate US trial, which is looking in patients with stage 3 colon cancer who are ctDNA positive after surgery, randomizing to either doublet or triplet cytotoxic chemotherapy. I think this is a cleaner design than the previous study, and I think will give us more, clear understanding of really what the role of chemotherapy is in these high-risk patients. But this is chemotherapy, and I think we'll hear shortly, how chemotherapy plays out, in people's lives. Our question is, can we use more scientifically informed approaches to meet patients at their level of need when ctDNA positive? And this is really what our Intercept program at MD Anderson has done. It's a program looking specifically to look at patients who have had standard of care curative intent for colorectal cancer across all stages, monitor them with a tumor-informed ctDNA assay, and then if they're positive, hopefully take these patients to clinical trials for ctDNA positive colorectal cancer for treatment of minimal residual disease. If you have more interest in learning about our Intercept program, we've profiled already, and you'll hear about this more in detail later, thousands of patients with colorectal cancer. But I would refer you to our website, the Intercept website, pretty easy, crcmrd.org. Colorectal cancer, minimal residual disease, crcmrd.org. But you can find more about, learn more about our program, but also learn about the clinical trials that we have at any given point in time for colorectal cancer. We've looked in various clinical trials, to bring the best science. This was a paper published in Nature almost 10 years ago, which showed that TGF-beta promotes resistance to immunotherapy in colorectal, in MSS colorectal cancer. But one of the things that was very interesting was that immune cells are present in the CRC micrometastases, but as these tumors grow, TGF-beta pushes out all of the immune cells such that by the time you start seeing radiographic lesions on CT imaging, TGF-beta has already pushed out all of the immune cells and rendered immunotherapy ineffective. We did a trial at MD Anderson where we looked at a TGF-beta PD-L1 bispecific antibody, published this several years ago. But our idea was that if we can silence TGF-beta, we can keep the immune cells within the tumor microenvironment and then render these micrometastases susceptible to immunotherapy. Unfortunately, we didn't know until we tried, but what we saw was that there was massive progression on this particular trial, and we kind of published why that was several years ago. But I say this was a disappointing result, and not the result we had hoped for, but our passion to cure more patients with colorectal cancer has not lessened despite any of this. And this was a really nice quote somebody had shared with me last fall from Winston Churchill, and very much in my mind, motivates me and hopefully our group towards ctDNA informed approaches from Winston Churchill, and that's success is not final and failure is not fatal, but it's the courage to continue on that counts. And success will consist of going from failure to failure without the loss of enthusiasm until we find success for our patients. And our group here is very committed to this success for our patients. I want to highlight work that's being led by various investigators you'll hear about from our team today. These are the ones leading the current clinical trials, but you can see that we have various kind of chemotherapy-informed ctDNA trials. We have various immunotherapy trials for patients with ctDNA positive minimal residual disease. We have scientifically informed approaches with a very interesting CSF1R antibody. Vaccine trials have been opened recently, and then other kind of targeted and cellular immunotherapy trials. So our portfolio for intervention against ctDNA positive minimal residual disease is very large. We're very committed to clinical trials. And if you have any questions or have a patient who is in need of a clinical trial, please reach out to our group. We're here to help you to help your patients with the goal of curing more patients. And again, I'll point you to this crcmrd.org website. So just to kind of wrap up, our goals for today, are to answer these questions. Why are we doing this? Our next speaker will be a patient whose life I personally believe has been benefited by the use of ctDNA. We'll be talking more specifics about who is at high or low risk for recurrence based on ctDNA, inviting some really distinguished speakers to talk about the prognostic and predictive data around ctDNA. The other question is, when is the right time? So we'll be having different speakers talking about specific context of colorectal cancer management, where this is in-house ctDNA, fills in the care of these patients. And then, how can we best help these patients? And again, talking about our INTERCEPT program at MD Anderson, multiple clinical trials that we have available and are passionate about to cure more patients. So with that said, it's really a pleasure to get to invite, I would say, our keynote speaker for today, Belinda Prater, who is a patient of ours here at MD Anderson. She's here just to kind of speak on her perspective of what ctDNA has meant in her life, how the treatment has been informed, and what this experience has been like. So she is a great example of why we do what we do, and it's just such a privilege to have her here today.